will shift to next speaker, Professor Michael Failing. Please, John, start sharing his lecture. Thank you.
Okay.
I'm Professor Michael Failings from the University of Toronto, and I'm very pleased to join you virtually in this session sponsored by the Egyptian and World Neurosurgery Committee Academy. And it's indeed an honor to take part in this session. I'll be speaking about the challenge of mild degenerative cervical myelopathy, and I'll be stimulating you with some new knowledge related to the applications of genetics, machine learning, and advanced microstructural MRI, as well as some pearls around clinical decision-making to allow you to personalize management recommendations for these patients. At the outset, I'd like to thank Drs. Atul Goel and Dr. Sameh Morsi for their kind invitations to take part in this session today. And I hope to see many of you in person as the COVID-related travel restrictions ease. I have no relevant commercial disclosures, but I am the principal investigator on a number of clinical studies and guidelines that I'll be making reference to. In 2015, we coined the overarching term degenerative cervical myelopathy. This encompasses a variety of benign, non-neoplastic, non-traumatic pathologies that cause progressive cord compression. And importantly, this synthesizes two of the commonest entities, namely cervical spondylotic myelopathy and ossification of the posterior longitudinal ligament. Pathophysiology is defined by the confluence of static factors causing compression of neural elements as well as ischemia, dynamic factors which include dynamic compression, axial tension, deformity, and instability, as well as biomolecular factors related to intrinsic neural damage, and these include inflammation, ischemia, and excitotoxicity. One classifies the clinical presentation of degenerative cervical myelopathy using the modified Japanese Orthopedic Association scale. And this report shown on this slide is the validation of this metric. And so one looks at upper motor dysfunction in the upper extremities, motor dysfunction in the lower extremities, sensory dysfunction, as well as sphincter dysfunction. And mild, moderate, and severe are shown in this slide. In 2017, in the Global Spine Journal, we published for the first time guidelines on the management of degenerative cervical myelopathy. This is one of the key data slides from the systematic reviews that provided the evidentiary basis for some of the guidelines recommendations. And this shows the important impact of surgery on short-term follow-up, intermediate-term follow-up to 3 years, and long-term follow-up beyond 3 years. And this shows very large effect sizes and narrow confidence intervals, indicating very strong effects in general for surgical decompression. So for moderate and severe degenerative cervical myelopathy, surgery is clearly indicated as the preferred management strategy. But things start becoming a bit more gray with mild degenerative cervical myelopathy. And here, depending on the clinical presentation, one might suggest a course of non-surgical treatment with structured rehabilitation and careful follow-up, or depending upon patient wishes and surgeon judgment, surgical intervention. And here's really where the art and the uncertainty comes in. So mild DCM represents a key knowledge gap, but also an opportunity for innovation. So I want to share with you some pearls that will allow improved clinical prediction. We are now starting to get a better understanding of the natural history of mild DCM, but this remains an area that we need to define further. We need improved outcome measures, as well as biomarkers. And I'll present microstructural MRI, in particular T2 star white matter to gray matter ratio measurements, as well as various genetic biomarkers as key potential tools. So let's discuss a case. So here's a 67-year-old woman. Here are her sagittal MRI scans, which show a moderate degree of subaxial spondylosis with cord compression. She's presenting with mild neck pain. She has bilateral radicular arm pain, mild hand weakness. On physical examination, she did have early myelopathic features, and we judged her MGOA to be 15. So she was in the mild range, but clearly myelopathic. Here are her axial images at C5, C5-6, and at C6-7. So let's consider 3 clinical scenarios. Let's imagine now that this patient comes to see us and she has minimal neck pain, but she does have cervical stenosis, but she has no neurological symptoms and signs. So that's one presentation. Let's now imagine the patient has minimal neck pain, but has evidence of a cervical radiculopathy, so with arm pain, neurologic symptoms and signs, and cervical stenosis, but no evidence of myelopathy. And now let's imagine this scenario that I've presented, where the patient does have evidence of early myelopathy. So how do we advise the patient, and what will be the correct decision making? So again, we need to recognize that DCM is a form of progressive slow motion spinal cord injury. Some patients have a benign prognosis, but certainly many patients do not. And there are age-related degenerative changes in the cervical spinal column. These cause progressive cord compression. There's spinal cord ischemia, inflammation. This can result in neurological disability and functional deficits. And so we recognize that the earlier you manage the patient, the better they will do, but not all patients show progression. Now here's another example. This is a patient here with a mid-sagittal MRI scan. There's T2 signal change within the cord parenchyma. And again, what if this patient comes in with neck pain and no myelopathy, radiculopathy, or a minimal myelopathy? In other words, the 3 scenarios that I've painted. Well, here's one pearl that I will leave you with. Microstructural quantitative MRI is with us now. I'll present to you a tool that any of you can use with your neuroradiologist in your clinics. There are many tools that are available, and you should become aware of these as well. T2 weighted, T2 star weighted imaging to look at atrophy and compression, magnetization transfer ratios to look at demyelination, DTI and fractional anisotropy to quantify axonal injury, as well as T2 star weighted white matter to gray matter ratio. And this is the one that I think is particularly valuable. Julian Cohen-Haddad in Montreal has established a spinal cord toolbox. This is freely available online. This is a helpful tool for your neuroradiology teams to use in the analysis of these images. And this is the paper to which I'm referring. This is the description of the T2 star weighted white matter to gray matter signal intensity ratio. And here's what the images look like. And you can also separate the tracks using a Cohen-Haddad's spinal cord toolbox. And this metric is very easily done. It's a very simple ratiometric measurement, and it correlates with clinical presentation and is predictive of neurological deterioration. And this is what we're trying to prevent. So here's a normal spinal cord shown in cross-section, and here's what it looks like in the setting of degenerative cervical myelopathy. There's significant atrophy, there's astrogliosis in the dorsal horn, loss of white matter, demyelination, and axonal loss. So we want to try to prevent this. We recognize that spinal cord injury is a progressive phenomenon with cord compression, resulting in ischemia and subsequent injury to the vasculature, as well as loss of neurons, axons, and ongoing inflammation. The MRI can provide some helpful clues, even a conventional MRI. So diffuse T2 signal change, this is where you have long segments of T2 signal change, and segmental T2 signal changes, where you see these skip lesions, are associated with a poor baseline status and outcomes. So these are bad actors. And if you see a patient like this, they certainly are at high risk for progression. So in this focus issue, we looked at the various treatment options for degenerative cervical myelopathy, and there are excellent treatment options available. And we also recognize that the natural history of cervical myelopathy is not so great, and there are many patients that do decline over follow-up. In patients with cervical stenosis and no clear evidence of myelopathy, the presence of EMG or clinical symptom signs of cervical radiculopathy is predictive of neurological decline. And certainly these patients should be counseled about this risk, and I will recommend surgery to these patients. So here are the AO Spine CSRS guidelines again, and the quandary we have is really in the setting of mild degenerative cervical myelopathy, where the evidence to support management is relatively low, and only a weak recommendation could be made. So we're trying to balance the risk and the benefit of surgical treatment in these patients. This is a study that we published a few years ago, looking at the efficacy and safety of surgery for mild DCM. And this is a combined data set from the North American and international AO studies. So one of the important lessons here to learn is that patients with mild degenerative cervical myelopathy have a surprisingly significant degree of impairment on the SF-36. So you'll see here the population norms are around 80, and you'll see that there's a dramatic impairment in both the physical and the mental component scores on the SF-36. Surgical decompression does improve function, disability, and quality of life in patients with mild DCM, but this is a heterogeneous group. And two of the things to pay attention to are neck and arm pain. You can quantify this using the Neck Disability Index, as well as functional status. And here you can look at the SF-36 physical component score and mental component scores to guide your management. Now, if you apply machine learning and artificial intelligence algorithms, one can derive a principal component analysis. And many of these factors cluster together. So in patients with mild DCM, negative predictors of outcome include older age. So patients who are older tend not to enjoy as good a recovery of function. It may be reasonable to watch these patients. Medical comorbidities and smoking. So it's advisable to counsel patients to stop smoking. And interestingly, in this milder group, it's generally preferred to do anterior approaches, and it seems that the pain outcomes are better. So if we look here again to create an algorithm around mild DCM, the critical things to use in your clinic will be the SF-36. So if patients have a lot of impairment on the SF-36 and or they have significant pain as assessed by the Neck Disability Index, they will be very responsive to surgical decompression. And these are the patients that will really benefit. So let's come back now to the patient that I managed. So she did have evidence of an early myelopathy, and I did counsel her towards surgery. I was concerned by the fact that although she had mild DCM, she had an MGOA of 15, so almost in the moderate category, and she herself felt that her life was quite impacted by this. And again, these are the axial images showing significant multi-level cord compression. And I managed her with a multi-level anterior cervical discectomy infusion. She had an excellent outcome, MGOA 18, completely free of radicular myelopathic symptoms and signs. So fortunately for this patient, an excellent outcome. Importantly as well, mild DCM may not have such a benign prognosis. And when we looked at a cohort of patients in our clinic, largely with mild DCM who declined a surgical intervention, over 50% of these patients ended up requiring surgery within about 2 years. And conventional MRI was relatively insensitive to detect change. So here really, it's listening to the patient and doing a careful neurological examination and clinical history. Now, genetics may play a role going forward, and here is a snippet of data on the ApoE4 allele. And ApoE4 is related to a lipid and cholesterol metabolism, and it's critical to the physiology and normal functioning of neurons. ApoE4 has been linked to the development of Alzheimer's disease. Most patients have an ApoE3 allele, which renders them less susceptible to neuroinflammation. But the presence of an ApoE4 allelic status in a clinical series from our unit was clearly associated with worse neurological recovery after surgical decompression. And so this may be a very appealing genetic biomarker to look at. So in conclusion, surgical decompression is safe and effective for mild DCM, but mild DCM is heterogeneous. Pain, unsteady gait, weakness are associated with greater baseline impairment. And importantly, pain, and when patients perceive that they have significant impairment at a functional level, this is associated with greater gains. And in general, we counsel toward an anterior approach. The SF-36 is a useful instrument and may help classify patients in your clinic as to the ones that may benefit from surgery. So let's come back to the three scenarios. So with neck pain, cervical stenosis, and no myelopathy, surgery is not indicated. Careful observation and counseling of the patient is the way to go. With neck pain and evidence of radiculopathy, in general, I will recommend surgery because these patients are at higher risk for the development of progressive myelopathy. And with neck pain and early myelopathy, I would recommend surgery if the symptoms are having an important impact on quality of life. Future decision analysis will benefit from new approaches, including machine learning, microstructural MRI, and genetics, and I present you the ApoE4 assessment as a potential tool. And on that note, I'd like to close. Thank you for your attention, and pleased to address questions.
Thank you, Professor, for this excellent presentation. We have 5 questions from Professor Felling, and I will start sharing it on the screen. Please answer it on the chat box. This is the first one. Degenerative cervical myelopathy is classified into mild, moderate, severe presentation based on which of the following: clinical impression, Neck Disability Index, modified Japanese, NOIC scale, extent of code compression.
Sam, where are we going with this?
Answer it in chat box. Hello.
Dr. Same, did you want me to go over the answers after you go through the questions?
Yes, sir.
Okay, I will be pleased to do that.
Okay, thank you, sir.
Sam, Uday Gupta has a question. Do you see that?
Okay, we will ask it after finishing these questions. Okay, next one. In patients with cervical cord compression, an MRI, but no evidence of myelopathy, surgery is a valid option in which of the following scenarios. All patients with cord compression on MRI should have surgery, regardless of whether there is frank myelopathy due to risk of spinal cord injury. Patients should only have surgery if there is T2 signal change. Patients with the cervical radiculopathy, clinically or electrophysiologically, are at high risk of developing cervical myelopathy, and hence surgery is a valid option. Surgery is never indicated in this patient. Okay, next one. Which of the following is the correct answer regarding mild degenerative cervical myelopathy? Neck pain and or arm pain is all key driver for patient to desire surgery. Many patients with mild DCM have surprisingly significant functional impairments, as assessed by SF36 score. Surgery is effective in improving pain and the quality of life in patients with mild DCM. None of the above, all of the above. Last one. Which of the following shows promise as a biomarker to guide decision making in patients with mild degenerative cervical myelopathy? Serum GFAP levels, serum albumin, T2 gray matter white matter ratio in MRI scan, ApoE4 versus ApoE3 Alex status, C and D are both correct.
Great. So perhaps, Dr. Same, we can go back to question 1, and I'll just walk through the answers while we're doing this. There was a question from Dr. Gupta around the role of surgery for moderate cervical myelopathy. And the overarching answer is yes, that surgery is recommended. And patients who progress from mild to moderate myelopathy are at quite high risk to become, to have a more severe neurological progression. So I think it's advisable to, in general, to operate on these patients. Can we go to question 1, Dr. Sami? And this really had to do with the classification of cervical myelopathy. So all of the factors that I showed in question 1, I don't know if you can share your screen to show question 1, but all of the factors, including the severity of cord compression and imaging changes, your overall clinical impression, these are all important factors, but the way we classify cervical myelopathy and what is referred to in the current AO Spine CSRS guidelines, published in 2017 in the Global Spine Journal, these reference to the classification based on the modified Japanese Orthopedic Association scale. So with regard to our lecture today, mild DCM is 15 to 17, and then moderate is 12 to 14, and then severe is 11 and less. And then the second question, I believe, related to decision-making kind of in mild myelopathy. So the current recommendations are that even if there's cord compression, if the patient doesn't have symptoms of preferable to observe the patient. The key driver for recommending in a non-myelopathic patient to have surgery is if they have radiculopathy. And EMG, electrophysiology, can be helpful because sometimes it's a bit tricky, particularly with upper shoulder pain, to figure out if it's true referred pain or not. But patients who have a cervical radiculopathy will be vulnerable for the development of cervical myelopathy. And then in terms of the decision-making in mild myelopathy, from the patient perspective, and what's actually quite helpful in the clinic is for you to recognize that the two key drivers that will drive patients to want to have surgery, even if they're only mildly impaired, is one, if they have significant pain, either neck and or arm pain. So that's one key driver. And then the second key driver is if the patients perceive that they're quite impaired. And so it's quite easy while the patients are in your waiting room to get them to fill out a couple of questionnaires. One, you can assess their neck disability index, or NDI. And if they've got a lot of pain on the NDI, then the patients will likely want you to operate. And then the second one is if they have a lot of impairment on their health-related quality of life. And then we had a question then on the biomarkers, and this was just to try to get you to think about these. So the T2 star, white matter to gray matter ratio, is a very easy one. All clinical units, even at 1.5 Tesla, all of the manufacturers do have the software to run the T2 star. And the radiologists currently do this, but they don't necessarily tell you they're doing it. So you can request the radiologists to do a measurement of the T2 star white matter to gray matter ratio. We have the paper, and if you email me, I'm happy to share the PDF with you. It's very easy to do. And so it's what we have found is in the patients with the mild DCM, it's predictive of the patients which will show down the road problems. And then the ApoE4 allele, it's very easily assessed genetically. We're not doing it very much right now, but it is a genetic marker that's associated with a variety have repeated concussions and post-concussion issues are at much higher risk if they have an ApoE4 allele. And ApoE4 is a significant risk factor for the development of dementia of the Alzheimer's type. And we now, in the paper that I referred to, which was published in Brain, it is a risk factor for the development of cervical myelopathy. So it's just something for you maybe to think about. And I would encourage all of you to, to potentially look at this in your practices. And just looking at the questions. So I was asked a question, which I answered in the Q&A on rehabilitation. So rehabilitation is a reasonable option if patients are coming in with mild myelopathy and they're not so keen on surgery. There's not truthfully any rehabilitation protocols that have been actually shown or proven to make an impact, but it's a reasonable thing to try to do while you're watching the patient. So, people are keeping an eye on them. And then I do encourage the use of rehabilitation as an option post-operatively. I think it's quite helpful, and I suspect most of you are also using this. And then in the chat line, I just saw that Dr. Gupta had a question on moderate DCM and the patients coming in with 2 or more years of symptoms. And I guess there are 2 points here. So one is that in general, patients with moderate DCM should have surgery unless they're too frail or have too sick or something. But in general, most patients should have surgery. And then I guess the implication from the question, I think, is it too long a period if they have 2 years of symptoms? And to be truthful, that's actually pretty typical. It's not ideal, but it's actually quite common for the diagnosis either to be missed or underplayed. And so certainly if someone came into my clinic with 2 years of symptoms, I would offer them surgery. I would have a discussion to indicate that ideally we would want to operate on people kind of earlier on, and there may be a kind of a reduced likelihood of seeing major improvement, but we do see significant improvements even in that scenario.
Thanks a lot, Dave, also for accepting our invitation and for this valuable lecture and questions. Thank you.